All right, welcome back, everyone. What we're going to cover now, before I get into the appendicular skeleton, or the extremity, the upper and lower extremity, I wanted to cover the cranial nerves as it relates to the skull. Okay, so let me do a screen share and let's get back into, let me see if I can find it. A second. There it is. Okay. So this is a picture. If we think of the skull and we cut this across, we lift the parietal bones off, we take the brain out, bird's eye view looking down. Here is the front, and then back here is the posterior side. So this little extension here would be the crista galli. Remember, in the nose, you had the vomer, perpendicular plate, and then it shoots up, become the crista galli around that little circle called a cribiform plate, which has all those punctured holes in it. The punctured holes are for cranial nerve number 1, the olfactory. Olfactory for the sense of smell. Now, if we move posterior to that, we have these two holes here called the optic canals. That's when, in the other video, remember I took the two sticks and I crisscrossed them, and that was where cranial nerve number 2, the optic nerve, crisscrossed. And the crisscross was right at that hypophyseal fossa, or the sella turcica. Hypophyseal fossa is where the pituitary gland sits. So the optic canal is the holes where the cranial nerve number 2. We talk about cranial nerves, they're always in Roman numeral. So on an exam, if you happen to see one of these foramen, it may say, maybe I'm not asking you what the foramen is, I may say which cranial nerve travels through there. And this will only help us when we get to neurology, because for the brain, we're going to cover cranial nerves, and I may ask which fossa it goes through in the skull. So we're learning it now, and it'll come back again for the fourth lab exam, which will cover the neurology. All right. If we move further posterior, here is the superior orbital fissure. So when we look at the skull, and you look at the orbits without the eye, there's going to be a slit that goes superiorly and then another slit that goes inferiorly in the orbit. So one's called the superior orbital fissure, not superior orbital foramen, because it's really not a hole, it's like a slit, so it's a fissure. There's a superior orbital fissure, and then when you look at the eye, there'll be an inferior orbital fissure. So please make sure you know those landmarks. Through the superior orbital fissure, look how many cranial nerves go through there. 3, 4, 5, and 6. Right? So if you look at it, here's 1, cranial nerve 1, cranial nerve 2, cranial nerve 3, 4, 5, 6, right? It's in order. So through the superior orbital fissure is cranial nerve 3, oculomotor, it moves the eye. Cranial nerve 4, trochlear nerve, moves the eye. Cranial nerve 5, sensation to the eye, it's the ophthalmic branch of the trigeminal nerve, V1, ophthalmic branch, which is sensory to the eye. And then cranial nerve 6, abducens, it abducts the eye. So cranial nerve 3, cranial nerve 4, and cranial nerve 6 all are responsible for movement of the eye, because there are 6 eye muscles to each eye. But cranial nerve 5, the trigeminal, the ophthalmic branch, deals with sensation to the eye. That's what, like if something goes in your eye or touches it, then your eye blinks. But something has to sense that something touched your eye. That's the V1. All right, if we go just posterior to that, here is foramen rotundum, foramen ovale, and then foramen spinosum. ROS, foramen rotundum, foramen ovale, foramen spinosum. Medial to that is the lacerum, which means lacerate. It's like someone took a knife and did this irregular laceration. So from anterior to posterior, it kind of makes this diagonal ROS, like Ross, foramen rotundum, foramen ovale, foramen spinosum, ROS. And then you have this lacerum, which is this knife-like irregular laceration. So through the foramen rotundum and then foramen ovale, that's where you have these two, right? They're all trigeminal, three divisions, V1, V2, V3. So V2, the second division, goes through foramen rotundum, and the third division of the trigeminal nerve goes through the foramen ovale. This one here is the superior orbital fissure for 3, 4, 6, and V1. So you got V1, V2, V3. Okay. Here's the internal auditory meatus. Here's the external auditory meatus. That's the hole in the outside of the ear. But if we go in on the petrous portion of the temporal bone, that's the internal auditory meatus. So the last cranial nerve here was what, 3, 4, 5, and 6, and now we're left with 7 and 8 go through the internal auditory meatus. Then we have 9, 10, and 11 go through the jugular foramen. That's cranial nerve 9. That's the, let me go back here, give you the names. 7 is facial nerve. Cranial nerve 8 is the vestibulocochlear nerve. Cranial nerve 9 is called the glossopharyngeal. Cranial nerve 10 is the vagus nerve. Cranial nerve 11 is the spinal accessory nerve. And then 12 goes through the hypoglossal canal, the hole near that magnum foramen. The hypoglossal canal is where the hypoglossal nerve goes through. That's cranial nerve 12. So you have 12 pairs of cranial nerves. Cranial nerve 1 goes through the cribriform plate. Cranial nerve 2 goes through the optic canal. 3, 4, 5, and 6, superior orbital fissure. V2, foramen rotundum. V3, foramen ovale. Then you have facial nerve and vestibulocochlear, go through the internal auditory meatus. Then you have glossopharyngeal, vagus, and spinal accessory through the jugular foramen. And then hypoglossal nerve, cranial nerve 12, goes through the hypoglossal canal. Okay? All right, now let's look at the axial, the appendicular skeleton. Altogether in the human body, right, there are 206 bones. All of them make joints except for that odd one in the throat that's called the hyoid bone. So in the other lecture, the other lab portion, we talked about skull, spine, sternum, and ribs. That's the axial. Appendicular is everything else. So we'll talk about the clavicle, the scapula, humerus, radius and ulnar, carpal bones, metacarpals, and phalanges. Then for the lower extremity, we'll talk about the pelvis, the innominate bone. That's made up of the ilium, the ischium, and the pubic bone that come together. We'll talk about the femur, the tibia, fibula, tarsal bones, metatarsals, and the phalanges of the feet. Let's look at the shoulder girdle. The shoulder girdle is made up of the clavicle. Let me get the pen on here. We'll get blue. It's made up of the clavicle, the scapula, and the sternum. Okay, those three bones make up the shoulder girdle. It's not the shoulder joint. When we talk about the shoulder joint, we're talking about this right here, which is the glenohumeral joint, right? It's the junction between the glenoid cavity or the glenoid fossa and the head of the humerus. So we call it the glenohumeral joint, which is that ball and socket joint of the shoulder. When we look at the clavicle, there is a medial end, or that clavicular end. Let's start over. When we talk about the clavicle, there's the medial end, which is the sternal end. And then there is the lateral end, which is the junction of the clavicle and the acromion process. So this joint here is called the sternoclavicular joint. And this joint here is called the AC joint or the acromioclavicular joint. So again, here is the medial end that articulates with the sternum. That's the sternal end. And then we have the acromial end that articulates with the acromion process, that highest point of the scapula. When you palpate from medial to lateral, the medial portion is convex, right? It sticks out. And then the lateral 1/3 is concave, it dips in. This is commonly fractured right about here when you fall with an outstretched hand, the clavicle fractures. Let's look at the scapula. First off, when we look at the scapula, we'll see we have one end that looks flat, one side, and then another side has this sharp ridge. So once you see this structure, the sharpness in the back, that's posterior. The anterior is nice and flat, okay? And then what else do we have? We have these two projections. Those are the two processes. We have a flat surface here, a flat surface here, a flat surface here, and a flat surface here. Everywhere we have these flat surfaces, they're called fossas. Everywhere we have projections, they're called processes. And then we have borders. There's a border here, a border here, and a border here. And then we have angles. There's an angle up here, and there's an angle here. Okay, so that's kind of like how we divide up the names. They're either borders, they're angles, they're processes, or they're fossas. So here we're looking at the anterior view. So here's a superior angle and an inferior angle. Let's look at the borders. Medial border, lateral border, superior border. Now the other name for medial border, the other name for the medial border is the vertebral border because it's closest to the vertebral column. The other name for the lateral border, which is where that glenoid cavity is, where the head of the humerus would sit, this is called the axillary border because it's the armpit, the axilla. So there's an axillary border and a vertebral border. The axillary border is the lateral border. The vertebral border is the medial border. The two processes, one that sticks out anteriorly, that's the coracoid process. One that sticks out up high, right up there, that's the acromion process. And then here's the glenoid fossa or the glenoid cavity. Don't confuse coracoid process with the mandible. That had the coronoid process. And there's also another coronoid process of the ulna. Don't confuse coracoid with coronoid. Coracoid is on the scapula. Now we're looking at the posterior. How do we know it's posterior? Because we see this spine of the scapula. The spine of the scapula starts right here at the root, which is off the vertebral border or medial border. Then it runs obliquely superior and lateral till it becomes the highest point of the scapula. That's called the acromion process. Again, superior border, lateral border, medial border. Superior angle, inferior angle. And then here is the glenoid cavity or glenoid fossa. Now let's look at the other fossas. When we find the spine of the scapula, right above it is the supraspinous fossa. So this is the supraspinous fossa. Below the spine of the scapula is the infraspinous fossa. So there's supraspinous fossa and infraspinous fossa. What's the key landmark that separates the two? The spine of the scapula. Then on the anterior surface, all of this is the subscapular fossa. These fossas are important because there are rotator cuff muscles that attach there. And let me change the color here. We'll make it red. Here is where the supraspinatus muscle originates. Here is where the infraspinatus muscle originates. Here is where the teres minor originates. And then back here is where the subscapularis originates. So the rotator cuff muscles, we call them SITS, S-I-T-S, supraspinatus, infraspinatus, teres minor, and subscapularis. And if there's a teres minor, there's also a teres major. It's just not a rotator cuff muscle. So I do a T with a little M for minor. So the supraspinatus originates, meaning it begins on the supraspinous fossa. The infraspinatus originates on the infraspinous fossa. Teres minor originates along that axillary or lateral border. And where are these three going to insert or attach? It's going to attach to the humerus at a very specific area near the head of the humerus called the greater tubercle. So we'll put GT here for greater tubercle. And then where does the subscapularis going to insert? If there's a greater tubercle, there's going to be a lesser tubercle. Now, right now, they're just words, but when we get to the head of the humerus, you're going to see the greater and lesser tubercle. Those tubercles are our attachment sites for muscles, okay? And the supraspinatus muscle is going to abduct the shoulder. The infraspinatus and teres minor are going to externally rotate the shoulder. And then the subscapularis is going to internally rotate the shoulder. So this is external rotation, this is internal rotation, or external rotation, internal rotation. Okay, different ways of doing it. Let's look at the humerus now. Let's look at the proximal humerus. So up here is the head of the humerus, and that's going to articulate with the scapula where you have the glenoid cavity or the glenoid fossa. That's the glenohumeral joint, primarily the shoulder joint, because it's a ball and socket. That's going to allow for circumduction, right? All the different shoulder actions. Make sure you watch the video on shoulder or range of motion of all the joints so you know. Okay, here is the greater tubercle. Here is the lesser tubercle. So that means that supraspinatus, infraspinatus, and the teres minor are all going to insert there, and the subscapularis is going to insert on the lesser tubercle. Between the two tubercles is this groove called the intertubercular groove, aka bicipital groove. What do you think is going to travel through the bicipital groove? The biceps tendon. Bi means two. So there's a short head and a long head. It's actually the long head of the biceps that travels through the bicipital groove. Okay, and there is a ligament that runs transversely that holds it down. And sometimes when that ligament is stretched or damaged, when people rotate, they feel a little clicking movement in there. And that's because that bicipital tendon can click and slide in and out of that groove sometimes. About 1/3 of the way down right there is a tubercle called the deltoid tuberosity. That's for the deltoid muscle. That large muscle around the shoulder joint is going to insert on the deltoid tuberosity. When we move down to the distal end of the humerus, there is a medial epicondyle and then a lateral epicondyle. The medial, if you palpate along the inside of your elbow, not the knobby part, but inside, it's certainly more prominent than the lateral epicondyle. And the reason why the medial epicondyle is so very important, it's because if you, let me see if I can do this. So if I flex my fingers right here, you can see how at the medial epicondyle, these muscles here are going to contract. Just when I pump my hand, or even if I flex my wrist. So if I flex my wrist or move the fingers, you should see movement right along the medial epicondyle. So all of the wrist flexors and finger flexors originate there, which is why a lot of people get golfer's elbow and they get that soreness right there at the medial epicondyle. When the lateral epicondyle gets sore, which is on the outside, if I extend, can you see that? So if I extend my fingers or I extend my wrist, right there, it's contracting, and that's at the lateral epicondyle. So that's what tennis elbow, they get lateral epicondylitis, and with golfer's elbow, they get medial epicondylitis. Remember, itis just means inflammation. So all the wrist extensors and finger extensors attach at the lateral epicondyle. The significance of the medial epicondyle is the wrist flexors and finger flexors originate there. So again, it's really important to know these major landmarks, because for the next chapter, right, for the next exam, for exam 3, we're covering muscles. And when we do muscles, you have to know the bony landmarks, because muscles attach there to move them. All right, so don't forget these bony landmarks. Okay, medial epicondyle, lateral epicondyle. Now we have this structure that's called a capitulum, and then this one here called trochlear. These are important landmarks because they're involved in making up the elbow joint. So these two bones here, so here's the hand, these two bones right here of the forearm are going to articulate with these two portions here, capitulum and trochlear. The capitulum, notice, is round, and so is the head of the radius. Whereas the trochlear is going to fit here in the ulnar, right at this trochlear notch. So that's going to help form the elbow joint. On the back side of the distal end of the humerus, oh, let me go back for one more second, because there's two other landmarks here that's important. Let me make them blue. So here is a fossa, and here is a fossa. This fossa here, just above the capitulum, is called the radial fossa, and the fossa above the trochlear is called a coronoid fossa. What's going to fit in the radial fossa is the head of the radius. What's going to fit in the coronoid fossa is the coronoid process. Here is the head of the radius. Here is the coronoid process. When your elbow is extended like this, no big deal. When the elbow flexes, the head of the radius is going to fit perfectly in the radial fossa, whereas the coronoid process of the proximal ulna fits in the coronoid fossa. On the posterior side, if we flip the humerus around, now we're on the distal end, but on the posterior side, there's a fossa here called the olecranon fossa. And that's because on the back end of the ulna, right here, right there, this is called the olecranon process. When the elbow is flexed, the olecranon fossa is exposed. When I extend the elbow, the olecranon process fits right there in that olecranon fossa. Okay, and then again, you could see this prominent medial epicondyle and the less prominent lateral epicondyle. Wrist extensors and finger extensors on the lateral side, and on the medial epicondyle side is where the wrist flexors and finger flexors are going to originate. So now we're going to look at these two bones here, which make up the forearm. The humerus is the arm. This is the forearm. The forearm is made up of two bones. We have the lateral bone I'll just put L here for lateral, and this one's more medial. Again, you're in anatomical position. So up here, this is the head of the radius. This is the radius, and this is the ulna. So when we look at the proximal ulna, we see here is the trochlear notch. And let me go back here. Let's erase this. Let me put the pen back on for you. Make it blue. So this portion here is the coronoid process. Coronoid, not coracoid. Coracoid is on the scapula. This part here, and you can see it more on the posterior, is the olecranon process. This is the head of the radius. Now, on the ulnar bone, right here, there's a notch. It's on the ulna, but it's called the radial notch. The radial notch is on the ulna. Then there's an ulnar notch that's on the radius, okay? But that's more at the ulnar notch is down here. Okay. This on the radius is called the radial tuberosity. This is where your biceps is going to insert. The biceps brachii will insert. Let's look at a close-up view of the proximal end of the ulna. Kind of looks like a monkey wrench, right? Like that. So from the side view, here is the radial notch. It's this nice groove right here for the head of the radius to kind of rotate in so that you can pronate and supinate the forearm. So it's perfectly notched for the head of the radius to rotate in there for supination and pronation. So that's the radial notch. Just remember the radial notch is on the ulnar notch is on the radius. That right there is the coronoid process. Here, right there, that's the trochlear notch. And this is the olecranon process. On the posterior side, olecranon process. Here's the head of the radius. This is the head of the radius. Where's the head of the ulna? At the other end. That's the head of the ulna. This right here is called the radial styloid, or the styloid process of the radius. It's pretty prominent. You can feel it on your thumb side, and you go right there. That's the bump that you can feel. Very, very prominent. It is a very important landmark because there's a muscle that goes from the lateral epicondyle, or the distal end of the humerus. So it's the end of this bone, and the muscle is going to go to the end of this bone, the end of the radius. It's called the brachioradialis. Brachio, because it originates here on the humerus. Radialis, because it inserts on the styloid process of the radius, or radial styloid. Brachioradialis. It's an elbow flexor. We call it the politician muscle, because it's going to flex the elbow in the neutral position. There are flexors that flex the elbow in the supinated position, and there's elbow flexors that can flex in the pronated position. But the brachioradialis is the politician muscle. All right, so again, now we look at the radial. Here's the head of the radius. There's the radial tuberosity. This is the shaft of the radius. And there's the radial styloid. So the head of the radius is proximal, but the head of the ulnar is distal. Again, that's the coronoid process, and that's the olecranon process of the ulna. Remember, in anatomical position, the thumb radiates out. The thumb and the radius are on the same side. The pinky and the ulnar are on the same side. At the distal end, Here's the ulnar notch. The ulnar notch is on the radius. The radial notch is on the ulna. Here's the styloid process of the radius. That's that prominent structure right there. Now we look at the wrist. So in anatomical position, right, if we look here, like this, so this is an anatomical position. Here's the thumb, and then here's the pinky. So when we look at the hand, there's 8 carpal bones, and there's 2 rows, a proximal row and a distal row. Proximal and distal. When we look at them, this is the posterior view. Here's the anterior view. So we're looking at anatomical position. And if we go at the proximal row first, there's 1, 2, 3, 4, 5, 6, 7, 8. There's 8 carpal bones. There's a proximal row, and then there's a distal row. So from lateral to medial, right, the thumb is lateral. You have the scaphoid, number 2, the lunate, number 3, the triquetrum, number 4, the pisiform. Then we'll do 5, 6, 7, 8, the distal row, lateral to medial. We have trapezium, number 5, trapezoid, number 6, 7 is the capitate, and 8 is the hamate. Okay. So the pisiform, number 4, sits anteriorly to number 3, the triquetrum. This right here, like if you were holding a mouse of a computer mouse, your pisiform is what is resting on the desk right there. Okay. Now there's also, I'm going to change this up. Let me make something red here. Let's make it red. So from here to here, there's going to be a ligament that runs this way. It's called the transverse carpal ligament, aka the volar ligament, aka flexor retinaculum. It kind of runs like my watch band going across. It's going to hold down, if this are the flexors going to my fingers, the volar ligament or transverse carpal ligament is going to hold these flexor tendons down. So the volar ligament would be the roof of the carpal tunnel, and then the carpal bones are the floor of the carpal tunnel, right? So you're going to have a roof, the roof, and then you're going to have the carpal bones of the floor, and now you have a tunnel. And what travels through the tunnel are going to be all of the tendons going to the fingers to flex them. So you've heard of carpal tunnel syndrome. There's the median nerve that travels through there, and all of the finger flexors travel through there. So if you overuse your finger flexors, whenever you overuse muscles and tendons, they hypertrophy, they thicken and get bigger. So if the tendons in the tunnel get thicker and bigger, what happens to the space of the nerve that travels through there? It's got to get smaller. It's going to get compressed. When that median nerve gets compressed, you get shooting pain to the first, second, third, and half of the ring finger. First, second, third, and half of the ring finger. You get paresthesia. It means abnormal sensation, weird feeling, pins and needles to those fingers. That's called carpal tunnel syndrome. That's when there's actually compression taking place in the wrist. 90% of the time when you have numbness and tingling here, it's not carpal tunnel. It's usually the nerve in the neck that's getting pinched radiating and referring down in there. Okay, let's go back. Let me erase if I can. There we go. And let's bring back the color. Let's go blue. So we've done the 8 carpal bones. You should learn them by proximal row and distal row, 4 in each. Now we have metacarpals. Carpal, metacarpal. Meta means after. So after the carpals are the metacarpals. You see that they're named 1 through 5. The thumb is number 1. Then you have 2. The birdie is 3. The ring finger is 4. The pinky is 5. Those are the metacarpals. Then we have phalanges. Now digits 2 through 5 all have a proximal, middle, and a distal phalange. Proximal, middle, and distal phalange. All of them do, except for the first digit. The first digit only has a proximal and a distal phalange. They don't have a middle phalange. So the thumb has a first metacarpal, a proximal phalange, and a distal phalange. Whereas all the other digits, this is the second metacarpal, proximal, middle, distal phalange. Third metacarpal, proximal, middle, distal phalange. So you have to be very specific. So on exam, if I were to point to this and I say name this bone, be specific, you would have to say third proximal phalange. If I pointed here, what is this? You would say fifth distal phalange. If I pointed here, you would say first metacarpal. If I pointed here, first distal phalange. Okay? All right, let's look at the pelvis now. When we look at the pelvis has this large ilium. It has a pubic bone and it has an ischium. When those 3 bones come together and fuse or ankylose, it creates this acetabulum, which is the fossa to make a ball and socket joint of the hip. It makes your major hip joint. The pubic symphysis would be this fibrocartilaginous disc that would be here. Okay, it's more of a vertical disc, not a horizontal, but it's fibrocartilage. All right, now when we look here, this is the iliac crest. When we follow the iliac crest to the anterior, there's an anterior superior iliac spine, and there's an anterior inferior iliac spine. When we follow the iliac crest to the posterior side, there's a posterior superior iliac spine, and then a posterior inferior iliac spine. The way we differentiate the anterior from the posterior is on the posterior side, it has this significant notch right here. This is called the greater sciatic notch. This right here is the lesser sciatic notch. This little bump is called the ischial spine. Okay, the ischial spine separates the greater sciatic notch from the lesser sciatic notch. And what do you think travels through the greater and lesser sciatic notch? Sciatic nerve. Again, on the other side, this is the greater sciatic notch. This is the lesser sciatic notch. And this bump right there is the ischial spine. Not to be confused with this one, which is the ischial tuberosity. Okay, the ischial tuberosity is where the hamstring muscles attach to. Okay. Okay, let me, actually, hold on. Let me erase that and let me just go over that again because I may have messed that up. So let me go back and review that again. Make sure I got the right pen color here. Blue. Okay. Greater sciatic notch, lesser sciatic notch right here, ischial spine. Again, greater sciatic notch, lesser sciatic notch, that ischial spine. This here is the ischial tuberosity. Ischial tuberosity. The ischial tuberosity right here is a major attachment site for your hamstring muscles. This is part of the pubic bone. That's anterior. So that's why this is the anterior superior iliac spine, anterior inferior iliac spine. Follow the iliac crest posteriorly. That's the posterior superior iliac spine, posterior inferior iliac spine. And then that deep vinegar bowl right there, that's the acetabulum or acetabular fossa. From the posterior, posterior superior iliac spine, posterior inferior iliac spine. Again, posterior superior, posterior inferior iliac spine. Here's the iliac crest. You can see a little bit in the front. That would be the ASIS, anterior superior iliac spine. Can't really see the anterior inferior. Maybe at best it's there, but you got to look at it from the front. This here is the ischial spine. This is the ischial spine. That's the greater sciatic notch here, greater sciatic notch. Lesser would be inferior to it. This is the ischial tuberosity, ischial tuberosity. Obturator foramen, the largest foramen. Obturator foramen, the largest foramen in the body. Again, you can see obturator foramen, ischial tuberosity. What attaches to the ischial tuberosity? Your hamstrings. It's the origin for the bicep femoris, semitendinosus, and semimembranosus. Those are the three hamstrings. The hamstrings extend the hip and they flex the knee. Here's the acetabulum or acetabular fossa. Here is the greater sciatic notch. That's on the posterior. Just think sciatic is always on the posterior, which means if here's the iliac crest, that's the posterior superior iliac spine, posterior inferior iliac spine, anterior superior iliac spine, anterior inferior iliac spine. The anterior superior iliac spine is an attachment site for a muscle called the sartorius muscle. And the anterior inferior iliac spine is the origin for one of your four quadricep muscles, which is the front of your thigh, called a rectus femoris. Again, we're trying to connect muscles with bones, because when we do muscles, you have to know where they originate or where they insert. Here is the pubic symphysis. That's that vertical disc. This is the pubic bone, and this is the pubic bone. There's your obturator foramen. This is the pubic arch. This is a male pelvis. If it was female, it would be much, much wider. Here's your sacroiliac joints. Here's your iliac crest. So this bump right here is the anterior superior iliac spine, anterior inferior iliac spine, anterior superior, anterior inferior. Sartorius muscle originates here. Rectus femoris muscle originates there. Acetabular fossa, ischial tuberosity for the hamstrings. Pubic tubercle, pubic tubercle. There's a ligament that goes this way called the inguinal ligament, and another one going this way, the inguinal ligament. Let's look at the femur, lower extremity. Here's the head of the femur. Here's the neck. Now remember in the humerus, there was a greater and lesser tubercle. Well, in the femur, there's a greater trochanter and a lesser trochanter. The greater trochanter is the attachment site for your glutes, like your glute maximus, medius, and minimus. The lesser trochanter is the attachment site for your primary hip flexor that's called the iliopsoas. Iliopsoas. The iliopsoas is really two muscles that come together to make one, the iliacus and psoas major. When the iliacus and psoas major come together, it's called the iliopsoas, which brings me, just want to go back here and show you one other fossa. Here, this is called the iliac fossa. This smooth depression is where the iliacus originates, right? The iliopsoas, so the ilio portion is called the iliacus muscle. The iliacus originates on what fossa? The iliac fossa, which is on the inside of that ilium. Okay. So that iliopsoas, or the iliacus, is going to insert on the lesser trochanter, and it's going to help you take that first step forward, hip flexion, to bring your femur forward. Okay, this is anterior, so this is the shaft of the femur. Then there is a medial epicondyle and a lateral epicondyle. And then at the very end, medial condyle and lateral condyle. The medial and lateral condyles of the femur are going to articulate with the top of the tibia. And you can see that there's going to be cartilage between it. It's called a meniscus. There's a medial and lateral meniscus there. So the condyles, the femoral condyles, are round, and it's sitting on the top of the tibia plateau, which is flat. So when you have a round surface on a flat, it makes it kind of slippery and unstable. So the innate intelligence of the body creates lots of ligaments. You can see there's ligament, the meniscus, there's the cruciate ligaments, and then the ligaments on the side, which are called collaterals. So they add and they try and give that knee joint, which is the largest joint in the body, a little bit more stability, because you got these round femoral condyles, whereas the top of the tibia is flat. Okay. On the posterior side, there is this line that's called a linea aspera. It's actually where your quadricep muscles originate. They originate on the back, but they kind of wrap around to the front. Again, you can see the greater trochanter and the lesser trochanter. Lesser trochanter is more medial. The greater trochanter is lateral. Okay. The kneecap is called a patella. There's the base that's superiorly, and then the apex that is inferiorly. Now, you can't really see the patella. You can see the shape of the patella, but that's because the quadriceps tendon is attaching to it in the front. But you can see the underneath surface that's going to articulate here, right? And then the quad muscles would attach to it, and then the knee would bend, okay? Let's take a look to show you here. So here's the femur, here's the patella, and you can see the femoral condyles are round, and the top of the tibial plateau is flat. So this is the thigh, this is the leg. The leg is made up of the larger tibia and the thinner fibula. So if we look up at top, head of the femur, greater trochanter, and then you have the lesser trochanter. On the posterior side, that's the linea aspera, that line. In the front, it's smoother, but in the back, you can see it's got that ridge on the posterior side. That's the linea aspera. There's the base and the apex of the patella, and now we're looking at the top of the tibia and the fibula. So here, this bump on the anterior tibia is called the tibial tuberosity, and it happens to be in the same horizontal plane as the head of the fibula. See that? The fibula head is there. But notice the fibular head doesn't really make the knee joint because it articulates inferior to the patella, inferior to the tibia, right? The knee joint is really the patella, the femur, and the tibia, not so much the fibula. The fibula plays a much more important role in the ankle joint because the lower end of the fibula articulates with the talus, and so does the lower end of the tibia. This is the medial malleolus and the lateral malleolus. So you can see that here. Let's review. Here is the tibial tuberosity. That's going to be where your quadriceps attach, the large muscles in front of your thigh. Here is the head of the fibula. This is the lateral tibial condyle and the medial tibial condyle. At the lower end is the medial malleolus and the lateral malleolus. The lateral malleolus, if I were to draw a line here, you see how the lateral malleolus descends further distally than the medial malleolus. And I could show you that here as well. If you look at the ankle, you can see that the lateral malleolus descends further distally than the medial. This is the ankle joint. You see that? And that's why inversion ankle injuries are much more common than eversion. This is the great toe. This is the pinky toe. Because the distal end of the fibula, which makes up the lateral malleolus, descends further distally, it's a block. It won't allow the foot to rotate or to evert. It inverts this way. And then you start to strain and sprain all the soft tissue structures on the outside of the ankle. That's why the outside of the ankle gets all swollen, bruised, and black and blue. Okay? So let's look at the ankle. This is a bird's eye view looking down. So here's the ankle. You're looking at it this way. So the most superior one, the highest up one, that's going to articulate with the medial and lateral malleolus is this one. This is the talus. The most inferior one, that's going to be the heel or the calcaneus. That's here. So you got the calcaneus. The most superior is the talus. Remember, the talus is this one here. That makes kind of like the hinge. It's the monkey wrench. Lateral and medial malleolus are going to clasp the talus so we can dorsiflex and plantar flex the foot. Dorsiflexion, plantar flexion. When the foot dorsiflexes and the heel strikes the ground, that's the calcaneus that strikes the ground. All right, so now we have their 7 tarsal bones. So we did 1, 2. Here's the navicular, which is 3. Then we have 4, 5, 6, 7. So 4, 5, and 6, these are called cuneiforms, and they're either referred to as the cuneiform 1, cuneiform 2, and cuneiform 3, or medial cuneiform, intermediate cuneiform, and lateral cuneiform. And then the most lateral of all the tarsal bones is the cuboid. So the first cuneiform articulates with the first metatarsal. The second cuneiform articulates with the second metatarsal. The third cuneiform, or the lateral one, articulates with the third metatarsal. Then you have the cuboid, that articulates with the fourth and fifth metatarsal. In the hand, they were metacarpals. In the foot, they're metatarsals with a T. Just think toes with T. Then you have phalanges. Just like the hand had phalanges, and there is a proximal, a middle, and a distal phalange, once again, of toes 2 to 5. So what happens to the great toe? There's only a proximal and a distal. There is no middle phalange of the great toe. The great toe is called hallux, whereas in the palm, the thumb was called pollicis or pollux. Pollicis or pollux. The great toe is hallux or hallucis. Okay, so there's a lot of analogous structures, right? In the hand, there were carpals. In the foot, there's tarsals. 8 carpals, 7 tarsals. 5 metacarpals, 5 metatarsals. Phalanges, there's 14. 3, 6, 9, 12, right? Proximal, middle, and distal for digits 2, 3, 4, and 5. But the thumb, as well as the, or I should say, the pollicis and the hallucis only have a proximal and distal. So there's 14 phalanges of the hand and 14 phalanges of the foot. Okay. This is what it looks like from the lateral view. Here is the talus, which is the superior tarsal bone. Then there's the calcaneus, which is the inferior tarsal bone. Then there's the navicular, right there, the cuboid, and then the cuneiforms. This is the lateral one. This is the intermediate one, and you can't see the medial one because remember, we're looking at this from the lateral view. Then there's metatarsal. This is 5, this is 4, this is 3, this is 2, this is 1. So the great toe or the hallux only has a proximal and a distal phalange, proximal and distal, whereas the others have a proximal, middle, and distal. And again, on the exam, be very specific. Here's the pinky toe, proximal, middle, and distal once again. From the medial view, you can still see the calcaneus, that's the inferior bone. You could see the talus, that's the superior bone. Medially, there's the navicular, which is there. Now you can see the medial cuneiform, which is cuneiform number 1. That looks like cuneiform number 2. And here, you can't see the third or the lateral because this is a medial view. Okay. You got your metatarsals and your phalanges. Here's the arch of the foot. The arch of the foot, when it's a high arch, it's called pes cavus. And when the muscles are kind of slack and lax, it flattens and you get a condition called pes planus. Pes planus is a overly pronated foot or a flat foot. And when it's supinated or high arc, they call it pes cavus. If the muscles here are pulling and they're really, really tight underneath, it's going to create a high arc. And you can get these calcaneal heel spurs right there. So when people get up in the morning, if they're barefoot and the heel hits the tiles or floor that's not carpeted, they get sharp, sharp pain. That's where foot orthotics come in handy with a heel spur correction. You can also get plantar fasciitis, which is where the plantar fascia underneath becomes inflamed and tender. So it's plantar fascia with an itis, plantar fasciitis. Okay. All right. So we hope you learned quite a bit. I'm going to stop that share. Let's stop the recording.